So this is going to be a talk about plumbing. So after Dr. Spice's talk, your mind can relax and you won't be quite as confused because it's just about plumbing, what we do every day. So this is a case about a pumpless circuit we used on a kid to assist in end-stage respiratory failure. I have no disclosures. So here's a picture of the boy with severe pulmonary end-stage respiratory. This is 12 months after heart-lung transplant. So you know my story is getting with a good light. Idiopathic pulmonary arterial hypertension is characterized by an increase lesions in the small vessels, which increases the pulmonary artery pressure and increases pulmonary vascular resistance. With that, the right heart has a lot of work to do, and if it can't get over that, it starts to fail. And RV failure is the main cause of mortality in these patients. If untreated, there's a 68% chance that the survival will be less than a year. And if they get to 5 years, there's only going to be 34% that do. Idiopathic pulmonary arterial hypertension accounts for 5% of all double lung and heart lung transplants. So our child is a 13-year-old male. He was diagnosed in 2011, and at that time his PVR index was 17 Wood. His condition declined, and by 2014 he was doing less well, but he wasn't quite doing so bad that he was on the transplant list because he's actually denied then. In 2015, between February and May, he declined more: fatigue, anorexia, abdominal distension, diarrhea, ascites, and many recurrent hospital stays. In May of 15, he was admitted to an outside hospital with declining health. He was transferred back to us to reevaluate the possibility for transplant. At that time, his mean PA pressure was 80. His Wood units were up to 22. He was on lots of therapy, and he'd gone through quite a bit of the therapy path for this disease. And he was on oxygen at night. So at admission, he has a high risk of pH crisis and maybe sudden death. So the plan was to try to stabilize him to get diuresis going, was trying to help protect the LV, try to get renal perfusion going, try to support the RV, and get him listed again for transplant. So he was in the ICU to begin with, and he went to the medical unit. He was in the hospital for about 2 months. And then on July 4th, he started having supraventricular attack. And so he was started on melatonin, and now he's brought back to the ICU. He was on lots of therapy. He had gone through most of the track of this disease to get him to this place. And when I saw him, when I first got called to the bedside, he was on his knees in bed, tripod position, just everything he could do just to take breaths, to try to keep his oxygenation going. He was really on death's door. And so I think what we did was just something to try to do something quickly. And so we came up with this device I'll tell you about. But here's the treatment for this modality, and as you can see, the arrow points to where we were. He had gone through a lot of the treatment modalities over the last couple of years. So on the 4th, we took him to the OR. The cath before we went to the OR, again, his Wood units were high, his PA pressure was high, his RV systolic pressure was high, 107. His systemic was 89. His right side was failing his left side was failing because his right side was so big. He started having supraventricular attack, and he was just declining. The plan was to put in a pericorporeal oxygenator shunt. And after hearing Dr. Scott yesterday, there's lots of people doing this, but we didn't know that. And so the main idea was we need to have enough arterial pressure to support the device. We need a low gradient device, which we knew the Quadrox was, so that was our first choice. And are hoping that the shunt would get enough cardiac output to work. It would be able to remove the CO2 and complete oxygenation. And the amount of shunt might be our barrier. So we, again, interdisciplinary approach. We had really great anesthesia. We have great anesthesia, and on this case, we had really great anesthesia. Patient went to the OR with an arterial line, a couple of peripheral IVs, and a PICC line with most of his drugs going through that. They felt that the induction would be very risky. So they thought that if he coded on induction, we wouldn't get out of the OR. So the decision was made to put him on femoral bypass. Before we left the ICU, anesthesia put topical lidocaine on every place that we thought we might poke him. And so that was starting to anesthetize the area. Then when they got to the OR, they used topical anesthesia again with small injections. They took a lot of time making sure that he felt nothing. And we were able to go ahead and percutaneously cannulate the groin, put him on bypass while he was awake. He was setting up about 45 degrees. And he made no sign that he had any pain at all. So we got him on pump at about 3.5 liters. He was then intubated, and because of his disease and his kidney problems, he had lots of ascites. So before we did the surgery anymore, we went ahead and tapped the abdomen, and we took out about 1,000 cc's of ascites fluid before we went on. The sternum was open. We found a very dilated right atrium ventricle and a dilated pulmonary artery. So the cannulation strategy was to cannulate outflow cannula to the oxygenator placed in the PA, return the cannula through the RV, or right atrium, to the left atrium. The reason for that is the left atrium was not very visible, and so they couldn't figure out how to get the cannula there. The cannulas were then tunneled out the chest. We were able to close the chest. So our circuit was a quadrox, some coated tubing that was non-heparin, 2 Berlin cannulas, both 12 millimeter, a 16 millimeter graft, and 2 connectors. Thoughts from the perfusion point of view was, would the heart be strong enough to take care of this circuit? And then what would happen if the heart couldn't? Would the flow be enough for gas exchange, not knowing how much flow would passively go through our device? And then what emergent plans do we need to put in place to address what might happen? So what we did is we put the circuit completely in the sterile field. The idea is we wanted to have as short a tubing as we could, since we were going to rely on the heart to do all this pumping. So we created a sterile field. We completely set a circuit up in the field, and then we also made sure that we had backup supplies. So basically the circuit was set up so that we had an oxygenator and a pump on the field sterilely, and then we had a pump offside the field so that we could keep this circulating de-air and make sure we could prime another oxygenator easily. The idea was, if plan went as planned, we would have an oxygenator, 2 pieces of tubing, connected cannulas, and the heart would do the work. But if the heart couldn't do the work, we had a sterile pump, sterile tubing, so we could still keep our circuit very small and still be able to use the centrifugal pump. Once we took out that piece that we were going to use, we put another one in so that we had a completely primed oxygenator at all times. I also wasn't sure how well we would do with not clotting this thing off. So there's what the circuit looked like on the field. And the graft was put through the right atrium to the left atrium, so to the Berlin. And so our circuit ended up looking something like this. We had an inflow to the oxygenator from the pulmonary artery, and then the outflow back through the right atrium into the left atrium. If we needed to, we could have put the centrifugal pump in. We had an arm that was sleeved so that we could get it up to the field and keep it sterile if we needed it. And so this is once we were closed, heads on the left and feet are on the right. And that's kind of where it looks, where the pump is setting right over the hips right now. Tubing small. You can see kind of dark blood going in, red blood going out. That was good. And when we got on, the echo still showed that the LV was poor. Before we went on, the RV pressure was 120, but now it's down to 60. We had bleeding. We gave FEBA. I knew we would give FEBA. It's kind of part of our culture now. And so that's one of my concerns with having enough stuff, that we could keep replacing this as we clotted them. We also, when we took out the TE, we had some bleeding. Because of his anorexia and malnutrition, his tissues were very friable. When they went into the chest, the skin and fat layer was very thin. But we finally did get him supported. We got the chest closed, and we were able to get back to the ICU with a lot of drips. So when we first went on, our flows were about 2.8, and then by the time we left the OR, we were up to 3.5. Our pre and post pressures were very similar to what you see on ECMO, pre 30 and post around 10. And our gases leaving the OR looked very good. ACT was 128. We had reversed all the protamine. We had given FEBA. We had a little bit of heparin going, but not much, because he had such a bleeding problem before we got to this point. So when in positioning the oxygen, we tried to keep it close to heart level so that the heart would have less work to do, having to go up hills or down hills. We kept our lines very short. We always had backup equipment available throughout this 9-day stint. And our pre's and posts were fairly normal, 19 to 43 on the pre and 5 to 21 on the post. And I'll give you some more show of how those numbers looked. Once we got settled into the ICU, we were still bleeding. We had a lot of volume resuscitation going on. We had a period of time where we had hypotension, elevated filling pressures, so we assumed it was tamponade. We opened the chest. There was some bleeding around the pulmonary cannula. We had to give several epiboluses. We did get the bleeding controlled. We gave more FEBA. Blood pressure was improved. We got the chest closed. And everything on the oxygen and the circuit looked really good through all this. The anticoagulation was turned off, and it remained off. So here's a circuit that we kept at the end of the bedside, just to always have it ready to go. It was primed, had a centrifugal pump in it. We had tubing clamps, sterile clamps, connectors, prep, so that at any time we could pretty quickly change the oxygen route, not knowing if we'd have much warning if it did clot. The flows ended up being much more than I expected, so we were flowing pretty well. We had a lot of RN education to do. One of the nice things, we're a pretty busy ECMO program, so we used RNs to take care of this kid. So they already knew ECMO knowledge, so they knew about pre and post pressures. They knew to watch for clot, so that helped a lot. We extubated the kid on day 5. We mobilized him on day 6, and luckily we got transplanted on day 9. So here's a picture of him sitting in bed with the oxygenator in front of him at chest level. What was miraculous, besides just him, is that when we first saw him, he was dire straits. And once we got him on, he felt so good, so quick, that by the time we extubated him, he was telling the nurses what he would do and what he wouldn't do. It was just night and day change over how he looked when we first put him on. He sat in the chair a lot. We have a really important occupational therapy team. Because we do a lot of VADs, they have worked a lot with our VAD patients, making sure that they exercise on their VADs so that we end up with healthy kids that get to transplant. So this is kind of part of our culture. So when we had him on this, they were part of the team, and they did a lot of getting him out of bed, range of motion in bed, to keep him healthy. We've had Berlin kids on tricycles going down the hallway where we're running with the Berlin pump trying to keep up with them. So we have a really active physical therapy group. So here he is standing up on the edge of the bed getting ready to go up and walk around. And the thing to remember, if you remember that picture when I showed you at the beginning, look how dehydrated and malnutritioned he is here. He was really sick. So we changed the oxygen out twice. The first time we changed it out, we were losing some of our PO2 transfer. Our pressures pre and post were okay though. I think maybe we changed out a little too early, but we were scared. We'd given all this FEBA, and he was doing so well, and we didn't want him to hit a place where we had to change this out quickly. So we may have changed that a little too early the first time. On the second transfer, we actually did have poor gas exchange, and we also started having delta change. And so here's the pressures. The number 1 is the pre and post on the first change, and the number 2 is the pre and post on the second change. So we were really seeing some membrane pressures go up to match with our gas transfer going down. While we were on pump, we gave a lot of blood at the beginning. So the first circle over on the left, that's just getting him out of the OR. But then we did really well once we were on the 9 days. The next time we gave blood was at the transplant. The yellow is urine. His kidneys kicked in after we got him on support, and he was actually diuresed quite a bit. The pink lines up at the top, that's TPN. So we're actually trying to get him more nourished. So we were on the 9th day, we gave him a heart-lung transplant. And this is kind of the timeline to get us from the beginning to the end. And the real important part of all this is we had this technology that got us there, but there was a lot of nursing care involved. There's a lot of nursing care involved to keep him well enough to stay in the hospital and get to us from the medical floor. But then once we got him on pump, there was a lot of nursing care that helped him get through those 9 days before we could transplant him. And so a year later, he's looking pretty good. Any questions?
Susan Engler. Paul, thank you very much for your presentation. That was very good, and I learned so much from you. And then when I worked with you in Stanford, too, your team is remarkable, and your nurses in anesthesia is just beautiful. I was just wondering, from this presentation you had with this patient, you know you wanted it with the low pressure, trying to utilize his own heart. No, but you still had the